Welcome to AMD, Emerging Treatments and Promising Research. I'd like to bring Dr. Sheidow back to the microphone.
So, part two. For part two, what I'd like to do is briefly, in most cases, other than for the wet part, and briefly for many reasons, but briefly touch on a few things. First, I'm going to touch on a few things as far as dry degeneration. I'm going to answer one question that was brought to me that wasn't part of the talk, but I think it's valid anyway. It's usually part of some of my other talks that I decided to leave out because I get off topic with it anyway. First thing being, one of the therapies for dry degeneration. One of the things that's coming down the road right now is something called an implantable microtelescope. If one has cataract surgery, one has their lens taken out and has a new lens put in. The new lens can be chosen to suit your eye, the size, the shape, and that lens is selected by your cataract surgeon. An implantable mini telescope is actually a combination of lenses, two lenses stacked, almost like a pirate's microscope. The idea being to provide some increased magnification for a patient, have it right in their eye, so that it's always there and working. It has been designed, tested, and used in Germany. It was designed by a Dr. Lipschitz, and it is being sold. It is not currently available, I do not believe. I know it's not covered by OHIP, nor do I expect it will be. It's an expensive device and has some downsides and some upsides. The downside being the device itself, as one can imagine, must be thicker, because you've got to put two lenses in, not one. And during the implantation of that device, there is concerns with regards to you have to make a bigger incision. There can be some damage to the cornea. But at the end of the day, it sits in the same location as a current lens. And it's being designed for people who have not had cataract surgery. So this is not something where you go get your old lens taken out and a new lens put in. It has a limited amount of magnification. And what it will do is it will take away a bit of your peripheral vision because it is more of a unit going into your eye as opposed to one big plate. I am not encouraging nor discouraging it. Certainly the science would say that it does provide some people who have moderate in-between macular degeneration a way of getting away from their magnifier, but it currently isn't something you can go have on your own. I'm going to briefly mention something that has already been mentioned and mentioned in a much better way than I will, retinal transplantation. What everybody asks and what I want to make clear is that at the present time, you cannot have a retinal transplant. It doesn't exist. You can have a corneal transplant, you can have your lens replaced, but your cornea and your lens are different because they are structural parts to your eye. Your retina is part of your brain. Or as we retina people like to think, your brain is part of your retina. It doesn't matter which way you look at it. It's a totally different thing. Right now, as Brian was talking to you earlier, they are working on stem cell transplants. They are hoping to do photoreceptor transplants. At the present time, there is no retinal transplants. There are studies getting going. It is the true hope for the future. Absolutely. If you look at some of my patients with severe dry macular degeneration, I think that's where the hope lies, is in being able to provide new pigment cells and or photoreceptors, whether it's through stem cells or transplantation, to provide a new structure to see. Isn't available right now. You cannot get into clinical trials in it. And I just provide a warning that I am sure, absolutely sure, and Brian probably knows where you can do it. You could fly someplace and have it done. That is not how research is done, or not how it should be done. And I'll come back to that point in a minute. There are different kinds of transplants and stem cell replacements. There's embryonic stem cells, there's ocular stem cells, and that is where much of the research is being focused right now, trying to determine which type will give us the most benefit, be the longest lasting, and which one can we actually turn into the best vision. There are lots of issues that need to be investigated by researchers like are going on across Canada, and that's the reason we need funding for more research. As far as therapies for dry degeneration, it's been a wholly and totally disappointing 10 or 15 years. We keep hearing about what's on the way, the new drop, the new pill, the new something to slow down dry degeneration. And certainly if you look back about 3 or 4 years, we were talking about a portion of dry degeneration called geographic atrophy. Basically, I often describe it to patients as the pigment cells are withering. They're withering and dying, and they're leaving you with a patch in which there is no pigment cells left. And if that patch is under center, you have no central vision. It progresses relentlessly. It progresses slowly, but it is relentless. And it is the form of dry that will take away people's central vision, just equivalent to wet. And so when I mentioned the 5% of people who actually do become legally blind, it's that group. There's been a lot of hope that there would be a therapy to slow down the geographic atrophy. And I guess I would say that the first hope that came along was a drug called fenretinide. We all know that vitamin A is important to our eye health. And we also know that it is the byproduct of our bodies using vitamin A that is actually toxic to our retina. And this product meant to lessen those byproducts. In animal studies, it was promising. In early human studies, it was promising. And a couple of years ago, what was called the Phase 2 study, and because you're listening to me, you're missing a good talk from Anne-Marie on what is a study. But a Phase 2 study is not the be-all and end-all, but it is often a good indication of what's going to go forward. And it was promising. And we thought that Phase 3 was coming here, to answer your question, that we would have a study for dry degeneration finally. And unfortunately, like with many things, when you look at the benefit and the cost, because understand, to run a clinical trial at the Phase 3 level probably requires upwards of $500 to $700 million. Pharmaceutical companies take a big risk going to Phase 3, and what it was felt with fenretinide was it looked good, it looked promising, but not enough to go the next step, and so fenretinide died. One of the other big things which we know is that not only is AMD genetic, but there is some belief and strong belief that our own body's immune system, and there are different parts to the immune system. We all know about antibodies, but the other portion of our immune system is called the complement system. And it is the complement which attacks things, but it is also the complement system that can go awry, and there are many different parts of the complement system. It is hugely complicated. There are several complement components which are currently being targeted for eye disease. The rheumatologists have been doing this for years. They've been using different drugs, and there are many new things on the market for rheumatology conditions, whether it's lupus, rheumatoid arthritis, etc., to stop the body's immune system from attacking the body. That's what an arthritis, and many of those arthritises are. Not like the arthritis I have in my knee from abusing it over the last few years, but the kind there the body is attacking itself. The complement system is similar. There are drugs out there that we are hoping will halt some of the progression because we know there is an association between the complement system and dry macular degeneration. And so some of the hopes are that some of the early studies, the Phase 1s, there is actually a Phase 2 study which is going forward. In Canada, we often don't see things until Phase 3 has come along, and we'll touch back on one of those things a little later. Before going on to wet, which was my next reminder, because understand, for a retina person to stand here without slides, I really feel almost naked. I talk with slides. I always talk with slides. It may be a crutch that I don't need, but because I don't actually have a script, and you can quickly figure that out because I go off topic. But my little reminder here would say start with the wet, but I was asked a question about a therapy called rheophoresis or apheresis. They are different. Rheophoresis was a treatment for dry macular degeneration, and essentially it amounted to doing dialysis for dry macular degeneration to take all the bad humors out of your body to hopefully prevent progression. And essentially what it was a risky way of cleaning your blood of things we didn't know that would help. And every time they came out with a different theory on how it worked. One of the things that I mentioned about knowing how research is done in a controlled and ethical way. To get someone into a study, you have to know the risks, you as the patient, and there has to be a benefit. And it has to be watched closely enough to make sure that what comes out of the research goes forward and doesn't need to be duplicated, because why reinvent the wheel? Rheophoresis was doing a study whereby patients were allowed the privilege of paying $20,000 to become part of the study. Well, that's not a research study. That's a marketing promotion. And when partway through the study, they ran out of money to keep the study going, they went public with the company to sell shares so they'd get enough money to keep the study going. And at the end, the data never got published, which is a good indication that it wasn't helpful. And that is not good science, because good science will take even a bad result and publish it so that it doesn't get reproduced. And so my current opinion should be obvious. I do not encourage rheophoresis for my patients. It has not been shown to be helpful. It is an expensive therapy waiting for an indication. So on to wet macular degeneration. It is the blight on our society right now, blight both because it takes so many people so far down the line of visual loss, but it is also a blight because of the cost. In Ontario last year, I just heard this week, we spent $70 million on Lucentis alone. We have seen huge progress, though, and the huge progress in macular degeneration has been in the form of wet, because if you look back to the 1980s and 90s, all we had was laser. In 2001, we got Visidyne, and then, as I mentioned, in 2006, along came Macugen, Avastin, and Lucentis, all within a very small window of time. It truly was the dawn of a new age. But that age has changed a lot, and since there's a lot of familiar faces, I'm going to skip over the part that I've already talked about Lucentis being born. But more importantly, what I want to talk about is how it's being used right now. Understand that when Lucentis came out, it was brought out as a monthly injection, period. Monthly forever. Monthly for the first year, monthly for the second year. That was how it was used. That's not how we use it, but that's how it was used. The idea being, it's like a blood pressure pill. You take a pill every day to control your blood pressure. You get a needle once a month to control your eye disease. It's no different. It's just a different way of giving it to you, and because it's so much more onerous, everybody wants off of it. I understand that. But the idea is when you put the medicine in the eye, the medicine wears off. It is not like a viral transplant of a gene that is producing medicine all the time. Our body eliminates anything foreign, and it eliminates Lucentis. But what they saw in those first couple of studies, which were very well done, was that in the first 3 months, people had their big gain in vision, and then over the next 9 months, there was only a little gain in vision. It plateaued. And so we all had this great idea that, oh boy, we can stop doing the needles. It wasn't a well thought out idea, but it was a great idea. One of the things that I'm going to mention right now is, in hindsight, we looked back at the data and we realized that what you don't want to surmise is that if you don't get your gain in the first 3 months, you ain't going to get it. The study clearly shows that there are a group of people in whom, at the 3-month mark, they haven't gained. They may have even lost a couple of letters, but they still become one of the people who win at a year. And so being a fast responder is nice, but it does not mean you will be a non-responder if you don't do it in the first 3 months. And that's important to remember, especially for me, when I'm treating somebody's only good eye. It's only about 10% of people who will have that delayed response, maybe a little higher. But it's important to remember that sometimes you're doing it to stabilize people. That portion can't be understated. And sometimes they will gain later, and so you want to continue to hold out a little bit of hope, even when the clinic is becoming an injection clinic where there's just too many people to manage. But the first thought, and it was a thought, was if the main gain is in the first 3 months, let's treat people for 3 months, and then let's do it every 3 months. Let's try to make this a little more tolerable on the patient and on the clinic. 2 good studies were done, one called PEER, one called EXCITE. And what happened in both of those studies is you had the big gain in vision, and then by 1 year, everybody was back where they started. And so what I like to call the non-thinking man's approach to giving needles didn't work. If all you have to do is give a needle every 3 months, it requires no thought, which makes it easy, but it requires no thought. And essentially what it did was not maintain the vision that was gained. But again, learn from the study, publish the data, look a little deeper. And what we found was there was 3 groups of those patients. There was one group that got a few needles, stayed stable, kept their vision right on through that first year. There was another group that kept some vision but started to trend back towards baseline. And then there was a group that just never got better. They are distinct groups. And maybe what we need to do is understand that it is not going to be one problem or one approach that is going to be treated for everyone. What we have to do is individualize the care for each person. And that concept of an individualized care is really where Lucentis therapy is going. The other thing we need to focus on is what the patient is expecting. The long-term goal, and I have learned, we do learn just like you do. Some of us learn slower than others. But what I've learned over the last 6 or 7 years is to encourage people earlier to stop looking at success as getting off the needles and look at success as maintaining your vision. Getting off the needles is a totally separate problem. Maintaining your vision is your goal. And if it's not, you will be disappointed by Lucentis and the therapies that are soon to come. So the goal is always maintaining your vision. And the sooner that you and I start talking on the same page, the better we'll be. Somebody smarter than me came up with the idea that, well, maybe once we get the vision right where we want it, maybe we can use all this technology to decide when and where to inject. And so the first individualized therapy was what we call Prn therapy. And what that did was take people coming in once a month, but instead of injecting them once a month, do an OCT, the optical coherence tomography test that I told you we use. And if fluid starts to come back, inject them right away. Use the technology to pick up the misbehaviors quickly, stop them before they lose vision. And what happened was in both of those studies, the Pronto, the SUSTAIN studies, we learned, and SUSTAIN was a great name because it proved that we can sustain the visual gain by doing that. Was it as good as monthly therapy? No. It's pretty close. There's also problems with those studies, but what it showed us was that we wouldn't go back to where we started. And so that was the first step forward. But again, looking back at the data, even within those studies, we saw there was different groups. There was people who responded to very little numbers of injections, and some who responded and needed almost monthly injections. And so it still wasn't individualized enough. And what also came around a few years ago was better technology. Our OCTs took a huge leap up in quality, and so the picture we're now provided allows us to pick up the disease recurring much sooner, and also to know who's not behaving well enough to deserve a break from the needle. And so what the new OCTs have led us to do is try to individualize things more. The other thing, if you live in Ontario, and I think it is similar in other provinces, is you can't have an OCT once a month. Ms. Matthews' statement that you can't pay for one and that everything's covered is correct. You can't pay for one and it is all covered. But you can't have an OCT once a month because you're only allowed 4 a year, or I'm only allowed to give you 4 a year. Now, in many cases, we do a few more than that if we have to, but that doesn't mean free is covered. I would argue that's the hospital, St. Joe's, helping your care. Why it's important is patients coming once a month, if you live, say, 2 hours from here, coming once a month for a needle and coming once a month for a checkup is the same thing. And we live in a wonderful country, but there's something called winter. And winter does necessitate problems getting to London from Kincardine or Windsor or Woodstock or whatever place you live. It even necessitates problems sometimes right inside London. And so for a Canadian patient, sometimes monthly checkups is as onerous as monthly injections. What came along before I go on to the next step was 2 further studies, one called the CAT study and one called the Harbour study. These 2 studies wanted to first of all prove that that PRN therapy, that individualized therapy, was not harming our patients. Because the first studies looking at PRN only showed could you maintain vision. But you can't compare one study in 2008 to another study in 2003. They're different groups of patients. And so these two went head to head. They had a group getting a monthly treatment and they had a group getting a monthly watch. And what they showed is that the monthly watchers were not inferior. Didn't say it was the same. Were not inferior to the monthly treatment. And so you did not jeopardize in a substantial way your vision by going to that monthly monitoring. The one study, the CAT study, was especially a big game changer south of the border because it also included the drug called Avastin, Avastin being a colon cancer medicine that we have regularly injected in people's eyes for many years. We injected it initially because we couldn't get Lucentis, and then we injected it because people couldn't afford Lucentis. Canada has been, because we are socialized and we take care of people, very quick to adopt coverage for Lucentis, and I applaud them for that. What the CAT study showed was that if you want to give monthly Lucentis, it is not inferior to Lucentis. Monthly Avastin, it is not inferior to Lucentis. But what it did show was that as needed Avastin could not be shown to be non-inferior. It might not be as good. That isn't an issue up here because everyone who has macular degeneration over the age of 65 is covered for Lucentis. I don't know why we would be using Avastin to that degree, but certainly there's a huge controversy which exists because of the cost difference in the drugs. And so there are things which have been told to us from the CAT study specifically about the use of Lucentis and Avastin that I won't try to bore people with here. Essentially, they are both good drugs. They both work in most patients, and there are subtle differences. I leave it typically to an individualized decision between you and your physician which one and why you're on them. One of the things that those studies showed, though, was that there certainly is room for improvement, both in visual benefit and in how we take care of people. And interestingly, if you did a survey of all retina specialists in Canada, the U.S., internationally, in this group we call the American Society of Retina Surgeons, and asked them how would they be treated, a big percentage, 65% of us, said we'd use treat and extend. That wasn't even what the drug was designed for. So here everybody's saying how they're going to use the drug if it was their eye was different than all the studies to date. And so the question becomes is, what's treat and extend, and why do you like that better for yourself and you don't give it to me? The idea with treat and extend is why not accept that everybody's a little different. There are people who need a once-a-month needle, so give them a once-a-month needle. Maybe there are people who only need a needle every 5 weeks or 6 weeks. Maybe some can go 8 or 9. Maybe you're even lucky you can do that every 3-month thing. Accept that people are going to use the drug differently, just like people need a different dose of blood pressure medicine or diabetes medicine. And so the trend has been towards individualized therapy in the sense of we still only have one real therapy that's covered. It's called Lucentis. But let's use that drug in an individualized way such that we find the right interval to maintain each individual's vision. It was certainly adopted very quickly in Canada because our patients were looking for fewer trips if they could have them and maintain their vision. And it's also what I would consider an ideal way of taking care of that person who's already lost one eye to a scar and who is now getting needles in their only remaining good eye because you don't want to jeopardize or take a chance that they'll lose further vision. There is a clinical trial being started across Canada called the CAN Treat. It's a treatment and extend study. It is only for new patients, as you asked. It's only for new patients because you need to prove that it is as good as monthly therapy, and the only way to do that is make sure everybody starts at the same point. If somebody's racing and has a 10-minute head start or a 10-minute slow back, it's not a fair comparison. And so it is a proper study in the sense that going forward, there will be 2 groups, one on the treat and extend arm and one on the monthly arm, to ask the question once and for all, is this a viable future treatment? Switching gears before talking about what's coming in new, I talked earlier in the first talk about throwing the baby out with the bathwater with vitamins, and the same thing can be said for treating wet. Understand that wet macular degeneration is not a single process, and it is not a single growth factor. It's complicated. Wet macular degeneration involves the signaling to start the growth of the blood vessels, the creation of a crack that the blood vessel can grow through, the formation of the blood vessels themselves, and then the budding of those branches like a tree. Then the development of a scar. There's many portions in this, we call it cascade. So why believe that one drug can fix all different parts of the cascade? And so there have been studies, ideas, concepts to ask, can we use more than one drug in the same manner that we use more than one chemo to treat cancer? Are these drugs additive in their effect? The first attempt at combination therapy was an attempt by the company to pair Lucentis with Visidyne, our old drug with our new drug. The idea being, we know Lucentis is the best thing going to stop the VEGF, the growth factor that starts this, and Visidyne can actually hit those blood vessels that have already started growing. The good news was it did no harm. The bad news was it did not provide any additional visual benefit to our patients. Additional visual benefit in the sense that it didn't make the 35% of people who gained vision gain more vision. And so there really was no added benefit in that way. Yes, it required fewer injections, not a hugely reduced number. And so from a cost perspective, the difficulty is you're taking two expensive drugs, putting them together for no real significant benefit. There are the odd individual who I still believe benefit from the combination approach, but in general, that combination hasn't been, going forward, a viable option. There is another drug which is currently available, not approved yet by Health Canada for macular degeneration, but approved for other things, called Ozurdex. Ozurdex is an injection of a steroid implant. I liken it to putting a little white fish food treasure chest inside your eye. It releases a bit of steroid for 3 or 4 months. There are some studies underway looking at the additional benefit of a steroid with Lucentis to see whether the two will result in additional visual benefit. Again, you have to see an additional benefit over Lucentis, both visually and or the number of treatments, because of the cost effect. But that's one direction things are being looked at, because they act in different ways. Steroids are good at cutting down on inflammation, and we know that inflammation plays a part in macular degeneration. We're just not sure whether the additional role of the Ozurdex will make a big difference. But it at least is a drug which is currently available that we're hoping will have some role. And then we get to what's going to come down the pipeline this fall. The next big game changer is going to be the drug called Eylea. Eylea, or better known as the VEGF trap, is still targeting the same way as Lucentis. It is targeting VEGF. And so it is not a grand leap in a new direction. It is a new version of an old treatment. But it is different in the sense that Eylea, instead of being an antibody or a portion of an antibody that grabs that growth factor, Eylea is mimicking or is pretending to be the natural receptor that would normally grab the VEGF. And so it's coming from a different angle. And because of that, it may have some benefits and some harms as far as how well it treats things. It has benefit because it has a higher, what we call, affinity. In a relationship, affinity is how strongly you feel towards the individual you're with. The stronger that is, the more likely you are to stay with that person. In the eye, affinity is how well it's going to bind to VEGF and hold it. Because if it doesn't hold, if it lets it go again, it's going to still go on and do its work. What we find is that there is some benefit in affinity, but how will that translate into better vision? 2 big multinational studies were done, called the View 1 and the View 2, which have clearly shown the benefit of EYLEA. There is no doubt it is a good therapy. It is a good therapy which, when compared to Lucentis, so not compared to doing nothing, compared to Lucentis, EYLEA is equivalent, not non-inferior, equivalent. The same number of people don't lose vision. About 95 out of 100, you can stop them from losing vision, same as Lucentis. About 35% of people gain vision. And so ultimately you can say, well, it's just the same. It's not quite the same. But statistically, over 2 years, EYLEA and Lucentis have to be felt to be equivalent. And why that's important to me is there are people who do suboptimally respond to Lucentis. I have people getting needles every 2 weeks. Not every 2 months, every 2 weeks. I have people who we don't dry up their retina. Their vision may be stable, but every time I look at their pictures, I'm waiting for them to lose vision because I know I can't get rid of that fluid. And so what I'm looking at is EYLEA as an opportunity. It may be the same in many people, just like Avastin may be the same in many people, but EYLEA is a new therapy that maybe this person will respond better to than that person. And so it is an opportunity to have one more tool in our armamentarium of tricks against wet macular degeneration. And it has also been hypothesized that the EYLEA may last a little longer. And so that person getting a once-a-month needle might get off the once-a-month needle. Maybe they'll respond a bit better and do it a little longer. I don't know on any given individual whether that will be the case. But I am greatly looking forward to that becoming available because we need more tools. It has been available in the States for almost 2 years, and because of some requests by Health Canada, it has been significantly delayed here so that Canada is actually one of the last countries going to get it. But nonetheless, we will be seeing it very shortly and understand that seeing it shortly and covered are two different things. We will not necessarily be switching patients over until it's covered, but hopefully coverage will follow shortly after. I mentioned earlier the complement cascade. Complement in the form of anti-factor D is currently in phase 2 studies. It is being looked at for geographic atrophy patients, and so that is a study which is going underway. And one of the big game changers I'm looking forward to is the studies coming forward with something called Fovista. Fovista is, again, an antibody. It is still a needle that gets injected in the eye, but it is targeting a different portion of the disease. It isn't going over that VEGF. It's going after another part that may have an impact on some of the scar development. I'm not saying it will eat up the old scar, but it may help prevent some of the scar that is developing. And so it's being looked at in conjunction, i.e., in that combination therapy approach with Lucentis or VEGF trap. And right now it shows great promise to give additional vision. The phase 2 study was presented. It showed that patients who were getting a combination of Fovista and Lucentis gained more letters than the patients getting Lucentis alone. And so that's great. We're seeing another step forward. But it's a phase 2 study and things can change in phase 3. The good news is the promise monetarily to the pharmaceutical company has taken it forward. It is starting phase 3 studies. They have actually started enrolling in the States, and it will be available here to some of our new patients in London. And so I guess if you look at the next big game changer for me, it's hoping that the Fovista studies go forward quickly and that drug becomes available soon. So what I'd like to do is stop there. There are many, many other drugs, so many that I can't even begin to start talking about them in half an hour, on the docket that are so far from being relevant, and they may, most of them, fail, that I'd rather stop and talk about those things or questions you have about our current therapies right now. Thank you.
You're talking about.
The question, and I'll just repeat it for you, but the question is not understanding the cost. The way drugs work in Canada is the first step to getting a drug is it must be approved by Health Canada for it to be sold in our country. And the simple example of that was in 2005, Lucentis was not approved. We could not give it to anyone outside of a study. Avastin was approved for colon cancer, and so we could get Avastin for another indication. But approved means available in the pharmacy. Lucentis is approved in Canada. EYLEA will likely be approved this fall, if not early in the new year. And approved means you can go to the pharmacy and buy it. In any province, there is in Ontario it's called the Ontario Drug Plan. The Ontario Drug Plan applies to seniors over 65 and only seniors over 65. And what that does is provide drugs for free, if you consider $2 or $2.83 free. I do, relative to the $1,700 Lucentis cost if you buy it in the pharmacy. But what you can do if you're on the Ontario Drug Plan is go get that drug with no additional cost. That is not the same as approved. A drug is approved by Health Canada to say that it is safe. A drug is covered to say it is paid for. And those are two totally different things, and coverage can follow 2 years after approval. It may be quicker than that, I have no knowledge, but the cost to the patient of EYLEA would likely be about $1,500 an injection once it is available. It's the same thing with Ozurdex. It is available, but it is not covered. And so patients can buy it if we think that they would benefit from it, but it is not covered by the Ontario Drug Plan. The Ontario Drug Plan does not cover all drugs that are in existence.
On existing Lucentis patients, any of the combination therapy available or only for new patients? Any of the combination?
Lucentis, I mean...
On existing.
Yeah, no, and existing or new would be the same thing.
Okay.
Lucentis is the, well, I want to say only, but that's not quite true. Lucentis and Visidyne are the only covered therapies for macular degeneration over 65. Only covered therapies. Ozurdex is not covered for anyone, and so adding it to something or using it by itself would never be covered either. The combination, they don't distinguish the combination, they distinguish the drug. And so when EYLEA comes on, EYLEA will either be covered or not, irregardless of whether you are already on something or whether you are taking something else. The catch there is when Lucentis came on, the Ontario government excluded Visidyne and said we couldn't use both. And so that is clearly written into the Ontario Drug Plan. And so from my perspective, if I want to give somebody Visidyne, I will use Avastin because it's an $80 alternative to use the combination because technically I can't use both Visidyne and Lucentis. But that's going to be similar when EYLEA comes out or Fovista. They will cover the drug or they won't. They will likely not specify new or old patient.
I was questioning, I've got lost the central vision of my left eye, and things are kind of blurry or double. Will I lose more vision in that left eye? Like I still see some there.
Once people get to the point where they can only count fingers or read the big E on the chart, the best example is, close your good eye, look at somebody's face. If you've lost the details of their nose, their eyes, their facial recognition, you've lost the majority of your central vision. Typically with wet macular degeneration, and understand I have a massive macular degeneration practice and I have a small handful of people that have ever lost their peripheral vision. Almost to the point I could count each one on my fingers. So when you ask if you're going to lose more, in general the answer is no. Once you've lost your central function, you've lost your central function. There are varying degrees on how big that scar is, but degrees on how big the scar is, in my mind, don't necessitate treating somebody with a monthly needle for a scar, especially if they've got a good other eye. If you've lost all your central vision, why keep injecting it if it's not affecting their quality of life? And so there are one-eyed people whose good eye has some scarring that we keep treating because what we don't want to do is allow the enlargement of the scar and the loss of some of those qualities that they currently enjoy, whether it's a portion of facial recognition, some low vision aids, things like that. But if your right eye is good and your left eye has lost all its central function, there is limited, if not no benefit, to keeping on going with injections, and you are not going to lose your peripheral vision. I would never encourage someone to have needles in the eye to save their peripheral vision. That's not how Lucentis works. The people who lose their peripheral vision are likely going to lose it whether I give them a needle or not, because that's a different form of the disease and we don't have a treatment for it. And so don't let somebody encourage you to have needles once a month out of the fear of losing your peripheral vision.
I wondered, is EYLEA covered for existing patients?
EYLEA is not even available,
I know,
so the answer is and when it comes available, what we hope is that coverage will follow shortly after. But who will be covered or will anybody be covered is completely up in the air. The answer is haven't got a clue. It would be nice to be consulted on these things or have some suggestions, and the answer is we're not hearing anything. So unfortunately, the answer is I don't have an answer. Either I did a better job or I did a worse job. Fewer questions.